Good morning. My name is Marcela Howell. I'm president and CEO of In Our Own Voice, National Black Women's Reproductive Justice Agenda. And I would like to welcome you all to our congressional briefing, Why Black Moms Need the Momnibus and Postpartum Medicaid Now. In Our Own Voice, in partnership with 8 state Black women's reproductive justice organizations, works to lift up the voices of Black women leaders on issues that impact our lives. This week marks our 7th annual Reproductive Justice Week of Action, where in collaboration with our 8 partner organizations, we amplify the voices around poverty, policy and culture change issues that are critical to the health and well-being of Black women, femmes, girls, and gender expansive people. And right now we're at a pivotal moment in our nation's maternal health policies. In fact, as we speak, the House of Representatives Build Back Better Act, a budget reconciliation package that has key investments in maternal health, is awaiting passage from the House, and then we'll head over to the US Senate for consideration before it gets to President Biden's desk. Specifically, the package includes key investments from the Black Maternal Health Momnibus Act of 2021 and permanent year-long postpartum Medicaid coverage for every mom in every state. These provisions were included in the Black Reproductive Justice Policy Agenda, a first of its kind document created by over 30 Black women's organizations and reproductive justice advocates. The policy agenda provides a roadmap for how Congress can provide policy solutions for the issues that impact the lives of Black women and gender expansive people. We are fortunate today to be joined by 3 reproductive justice and birth equity leaders to discuss this historic moment. Dr. Joia Perry, who is the founder and president of National Birth Equity Collaboration. Angela Aina, who is the co-founder and executive director of Black Mamas Matter Alliance. Chanel Porchia Albert, who is the founder and CEO of Ancient Song Doula Services. And Aina Nedhari, who is the executive director of Mamatoto Village. But before we begin hearing from these experts, we have video remarks from the Black Maternal Health champion in Congress, Lauren Underwood. And we're going to then dive into our discussion. So let's first hear from Representative Lauren Underwood.
Hi, everybody. I'm Lauren Underwood, and I have the honor of representing Illinois' 14th Congressional District. And I'm a co-founder and co-chair of the Black Maternal Health Caucus. I'm excited to be joining you for this important briefing, and I'd like to thank In Our Own Voice, National Black Women's Reproductive Justice Agenda, for their leadership on behalf of Black women and families across the country. Over the past year and a half, COVID-19 has laid bare the stark inequities facing communities of color in the United States, particularly Black women. But we also know that these health and economic disparities long predated the spread of the virus in our communities. As we work to end this pandemic and emerge from the public health emergency, we cannot afford to go back to what was broken. It's time to build back better and ensure that every person can be healthy and thrive. In Congress, I'm particularly focused on addressing our nation's maternal mortality crisis and the stark disparities facing Black mothers and other birthing people of color. Black mothers in the United States are 3 to 4 times more likely to die from pregnancy-related complications than white mothers, and Native Americans are 2 to 3 times more likely to experience maternal mortality. One study showed that severe maternal morbidity rates for Hispanic people in New York were nearly double the rates for their white counterparts. And other research has shown that Asian American and Pacific Islanders have higher rates of maternal mortality during hospitalization for delivery, even after accounting for other factors that affect outcomes. To tackle this urgent crisis, I am proud to be the lead sponsor of the Black Maternal Health Momnibus Act, which I introduced earlier this year with Senator Cory Booker, Congresswoman Alma Adams, and now more than 180 co-sponsors in the House and Senate. The Momnibus includes 12 bills that will build on existing legislation to comprehensively address every driver of maternal mortality, morbidity, and disparities in the United States. We know that we cannot address issues like maternal health without an intersectional lens, considering both clinical and non-clinical factors that influence outcomes. That's why the Momnibus includes key investments to ensure that every birthing person has access to high-quality, culturally appropriate maternity care, from funding to grow and diversify the perinatal workforce, to trainings on implicit bias and racism for healthcare professionals, to data collection improvements that will inform clinical best practices. The Momnibus also includes policies to address social determinants of health, from housing to nutrition to environmental conditions like extreme heat and air pollution. The legislation emphasizes the need to provide funding directly to community-based organizations that are on the ground, doing the work, ensuring that Black women and birthing people of color receive the care and support they need and deserve. Since introducing the Momnibus, we've seen significant progress in advancing these priorities. One bill in the legislative package, the Protecting Moms Who Served Act, passed the House with unanimous bipartisan support, and other bills have already passed in committees, but we cannot stop until we've gotten all of these policies passed in the House and the Senate. And that's why the advocacy that you will be engaged in is so meaningful. By sharing your story and explaining to members of Congress and their staff why this issue is so urgently important, and by sharing more about legislation that can end this crisis, we will be able to get the Momnibus to the president's desk to be signed into law. Together, we can take the bold action that will be required to save moms' lives and racial and ethnic disparities in maternal health outcomes, and achieve true equity for Black women and all birthing people. Thank you for your commitment to this mission, and thank you again for the opportunity to join you today. I look forward to the day that we're back together again in person, but until then, take good care of yourselves.
Thank you, Representative Underwood, for your leadership on the Black Maternal Health Caucus. And so now let's turn to our panel experts. I'm going to start with Dr. Joia. Politicians and lay people are now familiar with the staggering statistic that Black women are nearly 4 times more likely to die from pregnancy-related complications than white women. We've heard stories from Serena Williams, from Beyonce, and other Black public figures with resources who've experienced near-death experiences in pregnancy. But few understand why this is happening. Why are Black moms dying at this rate or experiencing birth trauma? Is it racism or race that's to blame for these disparities? Dr. Joia.
Thank you so much, Marcela, and thank you for having us at the National Birth Equity Collaborative on this important panel, and to Representative Underwood for her leadership, as always, in this issue. So as an OBGYN who was taught in medical school in the late 1990s, which in my mind is not that long ago, that there were 3 biological races, Mongoloid, Caucasoid, and Negroid, I recognize that the unlearning of this harmful belief of a hierarchy of human value based upon skin color is important across our medical field. And it's important for us to really reframe the language of blaming and shaming Black people with the capacity for pregnancy for their outcomes, but understanding that it's actually racism, not the amount of melanin we produce, that causes the harm. We don't have different kidneys, we don't have different lungs, we don't have different pelvises. All we have different is the amount of melanin that we produce. So therefore, it is racism, not race, that's killing Black mamas and babies. So you have to ask yourself, what is a risk factor? Based on well-established data, risk factors are categorized as modifiable or non-modifiable, and healthcare providers use them to counsel patients on how they can avoid or decrease their likelihood of death or disease. Imagine every time you tell a Black mama the reason that she's at an increased risk of dying is because she has a risk factor of her Blackness versus the racism that's actually harming her. Knowing these risk factors allows patients to do things like get tested earlier for an illness. For example, participating smoking cessation programs, Risk factors can include attributes like fair skin, lighter skin color for melanoma, which you can't modify, but you can also add or cover sunscreen. But no one's saying that whiteness is a risk factor for melanoma. So why do we say that being Black is a risk factor for maternal death? We need to stop saying and teaching that Black is a risk factor for illness and death. And instead, we need to start telling the truth. It is the exposure to racism that is the risk factor and leads to increased health inequities. Health inequities start with root causes, also known as social determinants of health. Racism and white supremacy, class oppression, gender discrimination, and exploitation, these are the root causes of social determinants of health inequities. These social determinants of health inequities lead to both unequal distribution of disease and well-being, right? Because we also get people who get to hoard more stuff, a Trader Joe's and a Whole Foods versus a food desert, which causes increased risk of asthma rates in neighborhoods with poor quality housing and increased environmental exposure, as well as the psychosocial stressors and unhealthy behaviors that lead to weathering. Racism is the individual risk factor that is continuously looked over because it requires undoing and unlearning of white supremacy, patriarchy, and racial capitalism. Patriarchy and racism cause Black women in the United States to die at 3 to 4 times the rate of their white counterparts. But we haven't seen publications listing women as a risk factor for Black maternal health. We must start listing racism as a modifiable risk factor, like smoking is a modifiable risk factor for lung cancer, and then actively tax it, create rules and policies about it, and hold it accountable when it's at an individual and a structural level across our communities, because that is what's causing poor maternal health outcomes. We can do that. We can work together to dismantle racism. Thank you, Marcela.
Thank you, Dr. Joia. So let me ask Angela this question. Dr. Joia just explained why Black moms are suffering needlessly in this country, regardless of economic status, education, or zip code. Let's talk about the legislative solutions needed to address this crisis and explain what are these critical pieces in the House version of the Build Back Better Act.
Yes, good afternoon, everyone. Thank you, Marcela, and also thank you to Dr. Joia, Crear as well for you all's responses. I'll start off by saying that the Black Mamas Matter Alliance is a national network of Black women-led organizations and multidisciplinary professionals whose work is deeply rooted in reproductive justice, birth justice, and the human rights framework. As perinatal health workers, doulas, midwives, lactation consultants, community health workers, and providers, our alliance knows firsthand the impact that significant investments in Black maternal health will have on our patients, our families, and our communities ultimately. So in 2018, BMMA and other Black women-led organizations here on this live came together to create policy recommendations that would proactively address many of the systemic public health challenges, workforce development issues, and everyday experiences of Black birthing persons before, during, and after pregnancy. The Black Maternal Health Momnibus Act was the product of these efforts. That is why I am so glad to be here today as we work to see the Momnibus investments get over the finish line and to communities. The Build Back Better Act includes many of the investments outlined in the Momnibus, including $175 million in funding for local entities to address social determinants of maternal health, including $75 million exclusively for community-based organizations. Also, $275 million to grow and diversify the perinatal workforce, including $50 million specifically for doulas, $100 million for maternal mental health equity grant programs, $50 million to promote representative community engagement in maternal mortality review committees, and millions of dollars to address the impacts of climate change, advanced research, also at historically Black colleges and universities and other institutions, strengthen federal maternal health programs, expand technologies, and provide bias trainings. The Build Back Better Act also includes an extension of postpartum Medicaid from 60 days to 12 months that is mandatory, permanent, and with full benefits. We know that health coverage throughout the postpartum period is essential for maternal and child health, and particularly for Black mamas who are disproportionately uninsured or underinsured due to state policies and other structural barriers. Black women-led organizations and community-based perinatal workers have been on the ground doing the work of providing culturally sensitive and affirming care to Black mamas for years. Now it's time for the Senate to do its part in the fight for Black maternal health and include these investments in the final reconciliation bill. Thank you all so much for this opportunity to talk about this. Thank you.
Thank you, Angela. I want to go to Chanel. The Build Back Better Act includes investments in expanding and diversifying the perinatal workforce, including covering doula care. Can you tell our audience what is a doula and what is the importance of full spectrum community-based doula care for Black moms? And the last question, part of that question is, what is needed for you to scale up this model?
All right. Greetings, everyone. I want to thank my fellow sisters for laying the groundwork and the foundation in the conversation and really like building up to what it means to center hope and what it means to really push forth a narrative of change that starts with the doing. And I think a lot of that, Dr. Joia brought forth what the problem is, and Angela so eloquently sold what the Build Back Better Act can do in terms of policymaking. But when we talk about doulas, we're talking about community care work. We're talking about a framework that really centers the whole person, understanding that in order to provide equitable doula services, you need to be able to center the person so that they can center themselves, and that resonates throughout community. The doula in and of itself is someone who offers emotional and physical support, as well as when we talk about working within communities of color, in particular within Black, Brown, and Indigenous communities, we're speaking about advocacy. We're talking about what it really means to center the reproductive justice framework in action. We're talking about culturally humble and congruent care. We're talking about understanding how the impacts of the social determinants of health, and how you can't even begin to think about your episode of pregnancy without thinking about, do I have equitable housing? Do I live in a food desert? Do I have access to transportation? Do I have my basic needs, are they being met in order for me to really show up as my full self when I'm seeking out my reproductive health care? And so the doula essentially, and when I say doula, I'm speaking about the community-based doula in particular, not these traditional models that are not centered in looking at the intersections of care and what it means to show up as a person, as Dr. Joia said, of higher melanation, right? And experience an episode of care within an institution. And so what we're doing is we're really centering the whole and not the parts, right? We're addressing the episode of care and really bringing forth education and information, but we're also extending that care and understanding that what does it mean for you to have the equitable resources in place so that you can not only survive, but you can thrive throughout your reproductive life course. And that's the essentials of the full spectrum community-based doula, right? The full spectrum community-based doula is understanding that there are various different episodes within the reproductive life course. There's the act of wanting to be pregnant, not being pregnant, of wanting to be able to access care in terms of pregnancy, during childbirth, and then during the postpartum period, which is really critical, right? When we start to think about the Build Back Better Act, and its investment into postpartum care for the extension up to 1 year, you know, having that and being able to say, if I'm having an episode where I feel like I need to seek out a therapist or some, you know, a therapist of color, and being able to have access to mental health services, being able to have access to extended doula care where someone can come into my home and provide those necessary resources, you know, so that I can have the social support so that I can go through my parenting in a way where I feel affirmed. Is important, right? And what I believe is necessary in order to scale up these models is, one, we need to have the investment that's necessary, right? And a lot of that comes through the Build Back Better Act and really investing in the infrastructure, understanding that the doula should not be the main focus, but is only a component within a huger pie of what it means for us to really address inequities within the healthcare, maternal healthcare system, which is we need the nurses, we need midwives of color, we need various different midwives of color, not just certified nurse midwives, but what does it mean to support and lift up the CPM within the track of the work that they do? What does it mean for the perinatal workforce and the perinatal community health worker to have the necessary supports in place? The community-based full spectrum doula to have Medicaid reimbursement, but also through managed care plans, right? So we're talking about, yes, the policy aspect and the infrastructure aspect. What we really need is systemic change that is not just reliant on the workforce, but is really trying to look towards accountability mechanisms as well. What does it mean for these systems to be held accountable for the ways and the harms that they do to folks, and then people being able to have recourse for that when that happens? We need to be able to have systems that understand that community care frameworks are not like traditional Western models, right? We're talking about the components of bringing in our ancestral skills. We're talking about our lineage, our DNA, and how it resonates and how we're able to communicate with one another, right? And understanding that in of itself is seen through like a narrative of hope, right? It's centered in the foundation of care, right? Because we've always had community care frameworks. Now it's time for others to understand what it means for us to care for ourselves in ways that are affirming, ways that are centered, and ways that make us feel whole. And that goes through not just the policy frameworks, but how we're able to deliver those services and the resources that are made available, and us being able to do that. And then understanding when they may need to be reallocated in other places in order to address crisis situations like pandemics, right? When we have to switch up the ways in which we're able to deliver services in order to meet the needs of the community at that time. Because essentially what we're offering is responsive care in real time. And this is happening continuously. And so being able to do that in a way and in a foundation that is built on trust, that is built in equity, that is built in sustainability, that is built in harm reduction, and that is understanding of our cultural beliefs, is something that is essential in order for us to be able to scale up and to reach the higher heights of where we need to be. I want to thank In Our Voices for creating this platform and having Reproductive Justice Week of Action, National Birth Equity Collaborative, Mamatoto Village, and Black Mamas Matter Alliance, because they are all individuals of themselves, but organizations who every day are striving to center their communities in equitable ways. And so it's not that we don't have the tools and the resources, they just need to be, they need to recognize what we already doing. Because it's already
right
there. That's all that needs to happen.
That's right.
Give thanks.
Okay, so thank you, Chanel. That was great. So I want to go to Aza. You're a certified nurse midwife, and you're the executive director of Mamatoto Village in Washington, D.C. You provide comprehensive perinatal support services to Black and Brown pregnant people, and you have a great success record. You also run the Blue Sage Midwifery, which offers personalized care in the DC metro area. So why is the midwifery model of care the gold standard, especially for Black moms? And how would the investments in the Build Back Better Act better support your work and clients?
Thank you for that question. Thank you for my fellow sisters in this struggle for kind of leading the conversation today. I do want to clarify that I'm a certified professional midwife, which I'll talk about the distinction in a little bit.
Right.
But Black women and birthing people have always held space for one another during childbirth. This is not a new phenomenon. We've always sought ways to build and sustain our families, to transmit knowledge, and sometimes non-conventional ways because of the systems that we have been forced to navigate. Midwifery has always been the gold standard. Since the precipice of time, midwives have ushered in life. The midwifery model of care is one that is anchored in human rights, one that is anchored in reproductive rights and justice and birth justice. Midwifery in the United States, though, must be reimagined because it too has been victim to colonization and racism. And prior to the emergence of nurse midwifery, which until the late 19th century, was really led by Black midwives, who we refer to as grand midwives, and Indigenous and immigrant women who made up the majority of all midwives in the United States. But most midwives, who at that time were women who were once enslaved, they drew upon these traditional methods of healing, these traditional ways of knowing, and they passed down these practices through multiple generations, right? And so they learned this healing art and this practice through apprenticeship, often with another experienced or elder midwife, or with physicians who at the time were actually navigating the home as well. They were not practicing in the hospital. But when we get into the 20th century with the emergence of nurse midwifery, which at the time and even now is still overwhelmingly white, and we see the medicalization of birth become attended by OBs, that really set the course for Black midwives to almost be eradicated, particularly in the southern states. So there were blame tactics, there were laws, there were educational requirements that reflected the policies of Jim Crow at that time. And they made the practice of midwifery by those who were not nurse midwives almost impossible. And at the same time, we start to see parallels in Black maternal mortality and morbidity as birth moved out of the community and into the hospital setting. And by the time we get to the 1930s, only 15% of births were even happening out of hospital. And so despite the evidence that midwives reduced maternal and infant mortality, they were pushed out of practice. And so today we see the remnants of that still playing out, where over 2% of all of the midwives in the US, which is roughly over 15,000, are Black. And that includes all three pathways: certified professional midwives, certified nurse midwives, certified midwives, and traditional midwives. CPMs, they are community-based midwives who have historically faced uphill battles to get legislation to actually support their scope of practice, because there is a hierarchy that was created that centers nurse midwifery as the gold standard. Even though, again, that gold standard has been orchestrated by models of care that are not anchored in any type of cultural specificity or care models that speak to the needs specifically of Black birthing people. And so during a time when we need expanded options, care is often limited or non-existent in some communities. Black women and birthing people, especially those who are on Medicaid, are even more disparaged because they often lack access to out-of-hospital options, particularly home birth, because it's not affordable or it's not accessible and it is not covered by Medicaid. And for those who are birthing in a hospital, midwives oftentimes are not even an option or available in their communities. And so the barriers are great for those wanting to enter into the field. The cost of tuition, there's limited schools and programs that even offer midwifery as a pathway. There's social barriers such as lack of childcare, limited support. There's difficulty in finding equitable and anti-racist preceptors and clinical sites, right? And so when we think about all of this, we think about why the Build Back Better Act is necessary. I believe that families deserve care by those who see their inherent strength and assets, that they would deserve care that reflects their cultures, their values, that speak the same language, and for those who have shared histories with them. And so I believe that we need a decolonization of midwifery, which the investments in the Build Back Better Act support. We cannot continue to amplify and elevate one pathway of midwifery over the other, given the histories that have been steeped and baked in racism and harm. The Build Back Better Act makes critical investments in the Momnibus legislation that's been designed to grow and diversify the workforce, which include midwives, address social determinants in the impact of maternal health outcomes, provide funding to community-based organizations that advance maternal health equity, which oftentimes are incubators for cultivating the next generation of the perinatal workforce, and that has been historically redlined in accessing funding needed for sustainability and longevity. To address climate change, this legislation really gets to the heart of barriers, needs, and safety nets that chart the course for Black women, birthing people, and communities to thrive. It is not a Band-Aid, but a transformational and historic action. Black mothers cannot wait. Black families cannot wait. And justice for the lives of every Black and brown mother that we have lost must be reconciled. And in my opinion, this is the only way in lieu of providing reparations. An investment that boldly states that Black mamas matter, that Shalone Irving and Shaija Washington and Amber Rose Isaac and Tatiana Odom French and Kira Johnson and Yolandra Kadima and so many other names who are not named, but we must continue to remember that their lives matter.
Thank you. So I'm gonna mix this up a little bit because I heard some things from everybody and I think it's time for us to have just a real conversation here. I heard Chanel mention reproductive justice. I heard Aza, who just got through talking about actually Aza and Angela talking about the racism, Dr. Joia talking about racism in terms of the impact. All of this is about, it sounds like it's about trying to control Black birthing people's bodies. So let's just talk about that. Let's talk about what this would really mean. If you woke up tomorrow and this was a world where reproductive justice had been achieved, what would it look like for Black moms, for Black birthing people? Anybody? What would the world look like? This is your chance to just envision your world, the real world that you want. What would it look like?
Well, I mean, after Aza just preached, I just feel I'm a little resistant to jump in. So I'll go first. That way I'll just, decrease y'all's expectations about the level of, yeah, so the world that we want, I have a 28-year-old daughter. So when I do this work, it's really personal, right? I desire for her to have the ability to make the personal choices that she wants. I wish sometimes that our legislators would be honest about the policies that they're creating. They're personal to them too. They're about their personal agendas for their families. The last time I testified in front of Congress, one of the people said to me, one of the pushback was I used the word partner. And I remember the congressman saying, well, Doc, when you say that word partner, what it sounds like you're saying is that my son does not have to be responsible for his family. So what he was being honest about as a congressman who led a committee in the US House of Representatives is that he navigated creating policy based upon his individual desires for his family. So what I want us all to be honest about is that Black people want to be able to thrive. So we want policies that see us as fully human. And we want you to invest in our ability to see the future and not to try to police and control us. So my vision of a future of reproductive justice is one where you support our well-being, you support our ability to make our own bodily choices, you invest in our healing, you invest in our cultural beliefs, and you don't believe that your role is to control and dictate our behaviors and our choices.
Okay. Thank you. Anybody else? I know you all have a vision, so go ahead, Angela.
Yeah, I could go next. And thank you, Dr. Joy, because basically Aza and Chanel set the tone, honestly, of what really needs to happen and exactly what Aza so brilliantly said. There just needs to be a decolonization overall in how pregnancy and maternity care is done in this country in particular. And for me, just to even take it a little bit more personal, it would be great in a world where reproductive justice is actually being practiced, not just achieved, but being practiced every day. Would mean that when I go to the doctor and I say that I am interested in becoming a parent, that they'll take that seriously. there will be, that I will have actual access to a midwife who knows how to work with me and my body type as a woman of size, you know, and to help navigate with me that process of becoming a parent, you know, and I wouldn't be met with stigma and all other kinds of biases that, you know, I currently experience when going into seeking care from physicians who automatically dismiss my wants and needs into parenting, for example, or look at my body and other people who have bodies that are similar as mine as a environment that's detrimental to a fetus or infant. You know, and so these are the things that we are coming against every day. And so when we talk about a true decolonization of maternity care, this is what we mean. And part of that is, again, really investing in Black folks, Black women, Black systems of care that are actually doing the work at the local level, at the state level, and at the national levels. And so we're hoping that with this Build Better Back Act, that with really incorporating truly all of these components of the Momnibus Act, that it will at least be that first step into helping us achieve maternal health equity overall. And you can't get to the equity if you're not truly investing in these Black-led models of care, most especially, as Aza and Chanel mentioned, investments at the community-based level, especially community-based doulas and those who train community-based doulas, investments in Black and Brown pathways to, for Black and Brown people to take multiple pathways in becoming midwives. So that's definitely, you know, when I think about really being able to enact and achieve reproductive justice, specifically in maternal health, that's what I think about.
Okay.
I think it's also too, you know, when we talk about the decolonization of frameworks of a system, it's also about the eradication of the emotional colonization that Black, Brown, and Indigenous people face when they're going to seek out healthcare systems and care. So when I envision it, you know, as a mama of 6, you know, I see it as, you know, as a foundation for my children to rest upon, where I know that they're going to be safe and free from harm, where they're going to be seen, where they're going to be heard, and when they know that their genuine well-being in their bodily autonomy is going to be listened to, right? We're talking about, you know, a real incorporation of a human rights framework within the reproductive life course, which is missing, right? You know, oftentimes people are going into these spaces and they're being dictated to, they're being, you know, methods of coercion are being used. They're being talked down to, you know, in a condescending tone. And it's like the individual who is going to seek out care is already an expert in their care. They've lived with that body their entire lives. So what would it mean for us to take a step back and to be humble and to say, wait a minute, what does this mean to you? Right? And so that someone can come to an informed decision about their care, understanding that, again, given the complex identity that someone's coming with, is going to vary. It's going to be something that's very different depending on who is showing up and how they're showing up. And so I see it as, you know, when we see these clinics, right? There's these clinics that are up. They are, you know, offering full wraparound services where you're getting all of your needs met, right? You're seeing the midwife that you want to see. You're understanding that if you're seeing a midwife for your prenatal care, it doesn't mean that midwife is only offering prenatal care, and when it's time for you to birth, you're going to get some random person. It means that you have continuity of care. Right? It means that if I have housing insecurity, that I can go to that one location, being that maybe I have children and I can't go here, there, and everywhere. I can get my social needs met as well. I can get food if I need food. I can get, you know, I can have childcare that's accessible so that I can make my prenatal appointment, right? And know that my child or my children are going to be taken care of at that time. Again, we're talking about really centralizing community care frameworks in an intentional way. And that really just, and it also means like having if you want to call them tribunals, but these accountability mechanisms that are in place that are always keeping things in checks and balances, right? Understanding that policy is a wonderful thing. I love policy. I think it's great. It's a way for us to frame conversations, but we also have to think about the unintentional consequences that can come out of them, right? And how we are actively addressing that along the pathway, and understanding that a policy that is made in its immediacy is not something that somebody may need 2 to 3 years from now. So how are we revisiting these things in ways that really center the fact that as we get older, our needs, our reproductive needs change. As our children grow up, their reproductive needs change. And we need to really start to think about this from an intergenerational perspective, and not just a point of gestation when someone can get pregnant. Also thinking about the ways in which, as we get older in this work, and as people access community care frameworks, what does it look like for them? You know what I mean? What is it in terms of just language, right? Think about the language where we were using in 2008 and the language that we're using now in 2021, right? We have to continue to challenge ourselves to show up in meaningful ways that make us uncomfortable, that allow us to be vulnerable, to hear, to truly listen, to be responsive in a way that is addressing community, because approaches that have traditionally happened have not done that, right? And when we do that, then we find ourselves in situations where you have like Band-Aids. And I think Aza mentioned that we don't need this, this like glazed over addition. We need something that is continual and is everlasting. And so that's what I see. I see something that is going to be where we're robustly, always actively engaging. We're always actively challenging ourselves. We're always actively being able, because we're also seeking that healthcare too. We're not removed from those things. You know what I mean? As a 42-year-old, like perimenopause is real, right? So like, what is that looking like, now at this stage? And what is it looking like for someone who's in their 60s? And what is it looking like for somebody who's 12? You know what I mean? And understanding that all those things are important, and being able to access those in safe and equitable ways is also really important.
Marcela, do you mind if I just want to give like an example of something that Chanel said that was really important? So you can create a policy that then needs to change. And if you don't change, it's not just policies that you need, because the undergirding devaluation still exists. And I'm gonna give an example. I hope some of you here work in regulatory positions, maybe at CDC or NIH, or you work for subcommittees that you create regulatory policy. So as an OBGYN, because of racism, because of the history and legacy of white supremacy and eugenics, there was a form that was created by the CDC, because Congress told them to, that says you must wait 30 days before you get your tubes tied if you are on public insurance. How that is operationalized now, 40 years later, is that many OBGYNs are not able to perform a surgery on a patient because it's used as a tool of harm that keeps people from getting access to a tubal ligation. It's used as a deterrent to care, because we never changed the policy to meet the needs and the valuing of individuals. So just because you make a policy that says, I'm gonna give you this tool that says wait 30 days, the next thing you know, people in hospitals are showing up and saying, I would like a tubal ligation. And that person says, well, where's your paper, your form? You cannot have it. And they also desire at 42 to have a hysterectomy, and they have to then have a tubal ligation form signed and wait 30 days to get a hysterectomy. This is a policy that's a failure at this point, that was being used to try to mitigate the harm of racism, instead of having tribunals or some type of accountability for the actual racism. The form's not going to fix the racism. The form's not going to fix the racism.
Good. That's a good point. Aza, you were going to say more?
Just a little bit, and be really brief. I think you, just going back to your question about, what we envision is, kind of leading from a space of reproductive justice. I think, really understanding why there was a need to create a reproductive justice framework was to really give voice to those various forms of interlocking oppression that we as Black women and birthing people and as Black people really had to navigate as we move through our reproductive lives, right? And as we move through our lives in general, and really understanding that we cannot separate and disconnect the systems that we are forced to move through and navigate as Black people, as we think about our own physical bodies, as well as we think about how we move through that space of thinking about having children, of making that commitment to having children, of raising those children, of seeing those children through adulthood, and how we move parallel through that in our own lives, right, as women and as people. And so, you know, for me, when I always envision a future, I think about one that is led by justice, one in which people are not mistreated on the basis of race, and people who need the most help get the most help, because that is the only way, right? To me, that is not equity, that is justice. In one in which the value of life is based on not the function of being white or the proximity to whiteness, but based on the value of humanness, right? And I think that, you know, as we continue to dream big about the future, you know, thinking and knowing that oftentimes as Black folks, we create things as a compensatory mechanism for dealing, existing, and navigating a system of racism, right? And so all the frameworks that we come up with is just to explain our lives, right? To put into words for white folks why we need the things that we need, not because we don't know what it is that we need, right? And so just, you know, just remembering that as well, that reproductive justice is amazing, right? It explains so much. It gives us words, it gives us common language. But at the end of the day, it was a compensation for not being heard. It was a compensation for having your voice silenced. It was a compensation for continuing to be oppressed and marginalized. And so I just wanted to lead with that we have to have systems that are anchored in humanness, anchored in justice. And frankly, our healthcare model has to be one that is led by prevention and not by symptom management.
Chanel, you're on mute. No,
I'm just agreeing.
Ain't nobody going after Aza. Ain't nobody,
I know, but
Yes, go ahead, girl. Go ahead, tell
go
it.
ahead.
I want to pick up on that, what you said, because well, reproductive justice is grounded in a human rights framework and Black feminist theory. So one of the things that our organization does is it polls Black women a lot. We do these public surveys, we do these focus groups, and we've done a number of national ones, but we also have done a lot of state ones, especially in the South. And one of the questions that we ask in every single poll is, when you are thinking about starting a family or expanding your family, what are the issues that come into play? And we always expect, you know, that people are going to say, well, healthcare, whether I have a good, you know, doctor or doula or midwife. But also what comes into play are things like whether I have clean water in my house, whether I have access to quality food, whether or not there's over-policing in my community. Racism and over-policing come up really high every time we do this. And it comes up a good 10 to 12 points higher in younger women than in older women. Younger women who are in between 18 and 30, it will come up much higher because that's their lived experience. They're seeing this. And so where do we start? I asked you to think about the vision, but where do we start in actually making that vision a reality? Is it medical school? Is it public health entities? Or is it elementary school? I mean, where do we really start and how do we start this? And this is, you know, this is another one of those vision things. What is it we're not yet doing? Build Back Better has some good investment in it, but that's just the start. Who wants to even?
Yeah, someone, I think it might've been Chanel, that said we deserve providers that see us and value so what you're highlighting for me is reminding me of that, that when I practiced OBGYN in New Orleans, frequently the age group of women that I cared for also were the age group of women whose partners were in spaces that there was hyper-policed. Holly Grove, where my office was, had one of the highest rates of folks who have been mass incarcerated and people who were, there was always police presence everywhere. And so at least once a month or so, a patient would come in and say, the person who you might have seen on TV last night who was murdered, that was the father of my baby, right? And so my job was not to blame and shame her for that activity, but to find, or for that being her partner, or to be like, oh my God, I can't believe you told me that. Like, I value her as a human being. I value her pregnancy. I want her to thrive into the future. So my role as her provider is to support her in that moment. If we don't have providers that see them as people, as fully human, and understand that the hyper policing and the neighborhoods is causing the harm, not the individual choices of that birthing person, that she's doing something bad by picking this guy, and so forget her, and she doesn't deserve to have health care, and she shouldn't have to get to come to this hospital. That's the current way that our system is orchestrated. I should have been blaming and shaming her instead of supporting her. And so until we can find providers that say that's wrong, that is taking the blue pill and not the red pill, we have to hold accountable that we deserve that person, that birthing person, to be seen fully human and to be valued. And that reimagining is not going to happen just through policy. We have to hold accountable how we train providers. The OBGYNs are not going away. I want more midwives and doulas, but we currently have a whole bunch of OBGYNs who need a whole bunch of retraining and unlearning and undoing and understanding the history and legacy of how our field was started, why we police and hyper police people, why we don't value folks who show up and in neighborhoods who are hyper policed, and we don't see that that's our job and our role to actually hold them and to take care of them and not to blame and shame them and dismiss them. So the vision of really holding my profession, my field, healthcare, NIH, all these big institutions who currently their orientation, their positionality is blaming and shaming marginalized communities instead of understanding the actual real history that we are the people who are in the ground have actually been doing work despite the harm of the policies that have come out of places like the White House and NIH around eugenics and white supremacy.
Anybody else?
So I would I would say that so there's a Black man, his name is Neely Fuller. He's like well into his 90s, and he worked very closely with Dr. Francis Cresswell Singh, who was an amazing psychiatrist in DC. And they talked about these areas of people activity: economics, education, entertainment, labor law, politics, religion, sex, war, and Dr. Welsing added health as the 10th one. And what Neely Fuller said that is what happens in one area of activity affects all the other areas of activity. And that by dominating, so by white people dominating the victims of racism, who he refers to as non-white people, in one of these areas, also at the same time dominates them in all the other areas as well, right? And so if we, we have to look at the entirety of the problem, right? Healthcare is one aspect. Economics is one aspect. Education is one aspect, right? And just addressing health, which we should do, right, does not necessarily mean that we're going to address economics. That means that I'm getting better care, but I still don't have access to food. I still don't have access to clean water or clean air. I still cannot own a home in the community that I live in, and I'm being pushed out. I still am underemployed. And so when we think about the ways in which we must address and approach this problem, we have to address it with logic and reason and less emotion. We have to look at what history tells us so that we cannot repeat the mistakes of the history. But I do think that we have to take a bold stance to demanding justice as Black people, and not from continuing to accept crumbs. Like, we need the whole meal, right? Because for so long, all we have been getting is crumbs, right? We ain't even been getting an appetizer, right? It's literally the crumbs that's left over after everybody else is already eaten at the table. Black people are always the one to get the last, right? And so I think that it is time that we start putting ourselves first, that we start putting our interests first and our needs first. And Dr. Joia always says, if you get it right for Black people or Black women, you get it right for everybody else. And so with that, I always say I am committed to the liberation of Black people, period, and point blank. It's not that I don't support my Native sisters. It's not that I don't support my Hispanic or Latinx folks or any other group of non-white people. But as a Black person navigating and living this body, we got to think about our needs, right? And we also have to call into play that there has to be a reconciliation for the historical harm and the wealth of this country that has been built off the backs and the wombs of Black women and Black people.
Okay, now I put my glasses on because I've got a question, and the question is from Dr. Tony Bond, who was one of the Black women sitting in Chicago who developed the reproductive justice framework. And it's not so much a question as it is a statement. She said, RJ was not created as compensation. That would imply that we were centering the framework of white women. In fact, when we came together, we were envisioning the world we desired, the world we believed Black women had the human right to exist and thrive in. So this is what she's saying was that, does anybody want to just sort of add their expansion of that in the work that you do? As we're almost out of time, and I'm giving each of you a chance to just throw in the last word and say, this is what I want.
Absolutely. This is Angela, and I so appreciate that word for Dr. Bond on that. And definitely that is where we founded and came from the perspective of wanting to promote Black Maternal Health Week. Really wanting to stick to the ingenuity, the creativity, even the Black feminist praxis of thinking about what can we create to shift the narrative around Black motherhood and how Black women are thought of, viewed, and treated in this country. And so instead of centering those very oppressive and violent things that have happened to us, we wanted to center our joy, like I said before, our ingenuity in the work that we're doing. And that's all of what came out of why we wanted to uplift and just celebrate Black maternal health by coming up with a week and a campaign that does that showcase the work, especially all of the work of all the folks on this panel today. And really at the core of that is to continue to fight against a lot of the narrative that continues to drive this, the behaviors, the beliefs, these policies, these systematic oppressive ways in which that makes it seem as though it's okay to treat Black folks, Black bodies as if we're undeserving of basic human rights, in which we are. And so that's what I would put out there.
I also am always grateful for Dr. Tony and her being in the space and just saying that we recognize that the Momnibus needs to pass and that right now the pushback we're getting is from the same pushback that we got when they created reproductive justice years ago, and that we don't want them to tie our need to live and thrive as Black mamas to having the Catholic bishops telling us what we can't do around abortion. This has nothing to do. Those two conversations are distinctly different. And once again, we're at the same moment of being our bodies wanting to thrive are being thrown under the bus by a political agenda that does not include or value us.
Any Chanel, Liza?
Yeah, I mean, I would just say that the reproductive justice framework, in thinking about where it was and where it is today as a student of the RJ framework and understanding history, you know what I mean? The framework was designed to be able to address a problem and the needs of the fact that the Black women then and still today are always having to defend our humanity, our right to survive and to thrive, our right to be present and to have this human experience of just living. You know what I mean? A right to be able to stand firm and realize that I woke up this morning, I got up out of my bed. If I'm breathing, then I should have any right as any other individual my grandfather used to tell me they put their pants on one leg at a time, just like you. And so in that, understanding what it means for me to center my humanity in a way that affirms me and affirms my community every single day. And that is the same cyclical cycle that we are still having to affirm today because of the egregiousness of racism and the socialization that it has, and it continues to infringe on every system. And so the same way Aza has said that you can't address the parts without the whole, and that's what happens in the healthcare system too, right? We want to separate the things that are going on within the body and now understand that it's a whole system that needs to be addressed. So we're talking about the physical, the emotional, the spiritual aspect of it as well, right? And how it interplays with one another. If I spiritually feel at harm or at risk within my community because of the attacks that are continuously happening to me, well, then my body is going to respond to that, right? Physically and emotionally. And so in understanding that, what we're saying is that we know asking for permission, right? That we have always decolonized and have been decolonizing frameworks since the beginning of time. And this is why, I've developed in others, the Decolonized Birth Conference as a way to be able to show those intersectional point of views of what it means to stand firm, but not just talk about it in the theoretical perspective, but also to show and prove. And I know Aza know exactly what that means. What it means, like for us, as people who we knew each other prior to becoming into maternal health, right? And growing up in a framework where it's like, yo, show and prove. And so we're at this point where we're like, what does it mean for people to show and prove within the landscape that understands housing and climate change and all of the things that come up for us on a everyday basis? And we're not asking you for permission to live and to see our humanity. Whether you accept it or not, I'm here, and we're not going anywhere, right? And we're making strides to be able to address that in our communities in ways that affirm us and feel good to us, because it's our humanity that I don't have to justify that. I don't have to justify my humanness on a consistent basis.
Okay. And I do want to make one point, because we are at time, that it is really important that we have people talking to their members of Congress. The House of Representatives has the Build Back Better bill in front of them. We need to make sure it gets passed, and we need to make sure that it gets passed with the investments in maternal health that we all think are important and that we fought really hard to make sure got in there. And then we'll start on the Senate, because that's really where our problem lies, is making sure those same investments, because once it is passed on the House, it has to go over to the Senate. And we want to make sure, so everybody who's on, we had 98 people on listening to us today. Please make sure you talk to your bosses, especially if you work for any of them in the Senate, and make sure that the investments that are in there for the Momnibus Act and for the expansion of postpartum care stay in there, are included, and make it to the president's desk, because we know the White House is supporting this, and you've got a lot of Black women out here who helped you get elected and who are supporting this and expect that you're going to vote right. So I want to thank all of you, for coming on. This has been a great discussion. Thank you very much, Dr. Joia, as always. Aza,
having me.
Angela, Chanel. I always love listening to all of you. And I want to thank all of you for joining me today. And for all of those who came onto the webinar, if you need experts to testify, you got 4 of these great women who know about Black maternal health better than anybody else. They live this, they work it, and you can reach them. Do you want to give your websites? Even though I'm getting a signal saying it's supposed to, go ahead.
birthequity.org, and I have to go have another one. Thank y'all. Love y'all.
Aza?
Mamatotovillage.org.
Angela?
BlackMamasMatter.org.
Chanel?
AncientSongDoulaServices.com.
And you can reach me at blackrj.org. So thank you very much. And we are done. Bye, everybody.